will have our first lecture regarding the UGS about urinary tract infection, UTI, which is very important subject. The main learning objectives are to understand the role of the following microorganism. We have a group of microorganisms related to UTI. So we are going to talk about them regarding their laboratory diagnosis and susceptibility to antibiotics. Laboratory diagnosis in the sense of their general microbiological features. The microorganisms that I am going to talk about are the E. coli, gram-negative, some gram-negative bacteria, and some gram-positive organisms, which are the main causes of UTI. Secondly, to understand the different types of UTI in relation to the causative agents, that is to say, microbiologically. So I will start by dividing the urinary tract infections into upper and lower, upper UTI and lower UTI. The upper UTI related to kidney and ureter. Kidney, we call it nephritis or pyelonephritis, and we will discuss both of these conditions in relation to microbial agents. Ureter, ureteritis. Lower UTI regarding urinary bladder, urethra, and the prostate. Urinary bladder cystitis, we call it the inflammation or infection of the urinary bladder as cystitis. Urethra, urethritis. Or prostate, or prostatitis. So very simple. What are the predisposing factors for urinary tract infection? Poor personal hygiene, understandable. Sexual intercourse. Catheter, when you put a catheter in the urethra, for example, it may predispose the patient for UTI. So presence of a catheter in urethra will make the patient more prone to become infected, especially when it stays for a long time, more than 24 hours. How we protect against UTI? A frequent flushing by urination, urine voiding. The current of the urine will flush the urinary tract and you get rid of most of the bacteria that are present, for example, in the urethra. Second thing, acidity of the urine. The acidity of the urine, normally, the urine is acidic, of acidic pH. This will discourage the growth of microorganism, MO, microorganism, or organism growth. So acidity of the urine. Secondly, the presence of endogenous microbiota at the meatus of the urethra. These microbiota, that is to say, the normal flora that are present in this area, will prevent other microbes, including the pathogenic microbes, from colonizing the area, from coming to the area and inhabitate the area. So these normal microbiota sometimes are killed by, for example, antibiotics. This will make the area more susceptible to get infected. So let us start with the different types of infection and speak about them in relation to the microbes, as I said. Cystitis is an inflammation of the urinary bladder. Most common cause for it, E. coli. E. coli is the most common cause of cystitis. Other causes of cystitis could be gram-negative bacteria. For example, Klebsiella, Proteus, Enterobacter, Pseudomonas. These are all gram-negative bacteria. The first three are Enterobacteriaceae, enteric microorganism. They live in the colon. okay, and Pseudomonas, also gram-negative bacteria. These are other causes, but less frequent than E. coli. Gram-positive also can cause cystitis, Staph saprophyticus, Staph epidermidis, which we call them non-pathogenic staph. But a certain situation, they can cause infection, they can cause cystitis. Also, Enterococcus is another microorganism which was previously called Streptococcus group D. Candida albicans also can cause cystitis, although rare, especially in immunocompromised patients. Clinical picture of cystitis, the three main symptoms: dysuria, frequency, and urgency. What is the meaning of dysuria? Painful urination. The patient feels pain during urination. The frequency, that is to say frequent voiding, يروح للتواليت عدة مرات بكثرة. Urgency, call to toilet, cannot withstand even a few seconds. So they usually go to the toilet. Sorry, just a minute, please. شباب انتو المحاضرة هذه شو بالجدول عندكم مسجلة؟
باثولوجي.
Sorry about that.
المايكرو على الساعة 11.
الماكرو على 11. sorry about this حقيقي. أنا صورتها 10 بس من رخصتكم دا أشوف الدكتورة، لو أنتم منبهيني والله كان
السلام عليكم، ازيك يا دكتور زين؟ انا دكتورة دعاء مع حضرتك. انا دخلت مرتين قبل كده بس ما حضرتك تخلص. الو
دكتورة دعاء راح أرن عليكي بالتلفون، راح أخابركي. الو سامعيني؟
سامعين دكتور.
راح نكمل ودكتورة دعاء المحاضرة اللي بعديها. الباثولوجي راح يصير بعد هاي المحاضرة. اوكي؟ تمام عيني؟ شباب. اوكي؟
تمام دكتور.
يلا عيني. إذن what are the clinical pictures of cystitis? Dysuria, frequency and urgency. Dysuria means painful urination. Frequency, it means going to toilet so frequently, بكثرة. Urgency, cannot withstand. The patient calls to toilet immediately. The differential diagnosis between cystitis and urethritis, التهاب الإحليل, urethritis, urethra. In cystitis shows more acute onset than urethritis, more severe symptoms. The bacteria in urine makes the urine cloudy and malodorous. وريحة كريهة, malodorous يعني الرائحة. And hematuria present in 50% of the cases. Suprapubic pain and tenderness. When you palpate, when you put your hand at the suprapubic area where the bladder is present, you find it's painful and tender. No fever or general symptoms accompanied both conditions.
دكتور
Pyelonephritis, التهاب الكلية, is inflammation of the renal parenchyma. Now we are talking about upper. The main cause, again, E. coli, the most common, usually preceded by cystitis. So as if the condition starts with cystitis and then the bacteria migrate upwards via the ureter to the kidney. Also, it may spread via the bloodstream. Infection may come through the blood to the kidney. So either preceded by cystitis and then migrate upwards to the kidney, or the infection may come via the bloodstream. The clinical picture of pyelonephritis now is different. The patient will have a flank pain, ألم في الخاصرة. Flank يعني الخاصرة. With fever. Usually the fever is high fever, more than 38.5. Preceded or accompanied by cystitis, as we said. The patient will suffer from rigor. Rigor معناتها رجفة, يرجف المريض من الحرارة. Vomiting, diarrhea, tachycardia, and tenderness over the costovertebral angle, مكان التقاء العمود الفقري مع الأضلاع. We call it costovertebral angle. Septic shock may occur. Why septic shock may occur? Because the infection may spread to the blood and cause septicemia. Urethritis is inflammation of the ureter, one of them or both of the ureters. Infection again is from the bladder or down from the kidney. Now the ureter is in between the kidney and the bladder. So either the infection migrate from the bladder, so upward from the bladder, or downward from the kidneys. Urethritis, inflammation of the urethra. Now the microorganisms here is a bit different in urethritis. The most common cause is Chlamydia trachomatis. So remember, chlamydia is the main cause of urethritis. Other causes, Neisseria, gonorrhea, ureaplasma, mycoplasma. Those which are caused by non-Neisseria, we call them non-specific urethritis or non-gonococcal urethritis. فإذا الميكروبس اللي تعمل يوريثرايتس اللي هي مونايسيريا جونوريا, all of these are called non-specific urethritis, or we call them non-gonococcal urethritis. The patient will suffer from what? From dysuria, painful urination, urethral discharge, or both of them, dysuria and urethral discharge. Prostatitis, inflammation of the prostate. This condition is mostly not infectious diseases, is not an infectious disease. It is usually caused by bacteria or a virus or a fungus or a protozoa, so different causative agents, but the main one is bacteria, of course. Clinical picture of a prostatitis: pain, but where is the pain? Lower back, perirectal area, and testicles. Some bacteria, as in cystitis or pyelonephritis, that is to say the main cause is E. coli. Fever, the patient suffers from fever, chills, signs and symptoms of cystitis, and it may lead to urethral obstruction. You know, the prostate surrounds the beginning of the urethra. So once it is inflamed, become enlarged, so it will cause retention of urine, انحسار البول أجلكم الله. When you do rectal palpation, the doctor puts finger to palpate the prostate. It appears as boggy and tender. Boggy زي لمسة الطين. كيف لمسة الطين؟ It's called boggy and tender. Clinical capsule, you know, we usually concentrate on a clinical capsule. UTI, it can be simple cystitis, but also it can involve the whole urinary tract, from the renal, pelvis, and kidney, pyelonephritis downwards. The most frequent, the most important feature in cystitis is frequent urination, which is usually painful, as we said, and has burning quality. Painful, that is to say, dysuria. In pyelonephritis, different. Fever, general malaise, flank pain, and also frequent urination. Cystitis usually self-limiting disease, while in pyelonephritis, urinary tract infection may spread to the blood, and this spread of the microbes to the blood cause septicemia and septic shock. So it is very dangerous sometimes. So you have to treat pyelonephritis aggressively using antibiotics. Usually we use antibiotics intravenously. General notes about UTI. Cystitis is the most common UTI, especially in females. It's more common in female than in males. Why? The urethra of female is shorter than the urethra of the males. This will lead to the predisposition of the female to have cystitis. And there are other causes, of course. Remember, E. coli could be contaminant. And the E. coli present in the perineal area and at the urethral area, which is reservoir of UTI. Less than 10 serotypes of E. coli are responsible for the majority of UTI. يعني مو كل الإي كولاي قاطبة تعمل UTI. Certain serotypes, certain numbers, which have numbers, certain serotypes of E. coli, about 10, are responsible for the majority of UTI. And we will go into some details about this point in a moment. Sometimes UTI could lead to obstruction, as I said, in case of a prostatitis, in case of enlarged prostate. Instrumentation, when you put a catheter, for example, in the urethra and go to the bladder, this can lead to UTI again. 95% of UTI are caused by gram-negative bacteria, bacilli. 90% of them, 90 of the 95, 90% of them are caused by E. coli. Also, hospitalized patient may become predisposed to UTI, especially with Pseudomonas and Enterococci, which are gram-positive cocci, as I said in the beginning. So hospitalization, again, may predispose the patient to UTI, especially if the patient has or have catheter. Young active women, Staph saprophyticus, and we mentioned this. Catheterized patient, Candida albicans, especially if the patient is taking antimicrobial therapy, antibacterial therapy, or diabetic, DM, diabetes mellitus. Usually, such a condition is symptomless. Let us go into some more details about E. coli regarding urinary tract infection. We mentioned previously E. coli at different situations, but today we will talk about them in regard to the UTI. E. coli gram-negative, as you know, lactose fermenter, LF, lactose fermenter, that is to say, produce pink colonies on McConkey's agar. لون وردي من نزرعها على agar called McConkey's agar. It is indole positive. And you remember the INVIC phenomena, that is to say, indole, methyl red, V Vocosoproscour, and C citrate utilization. INVIC phenomena, the first two tests, indole and methyl red, are positive, while Vocosoproscour and citrate utilization, negative. I is just to make the word for a pronunciation, لنطق الكلمة. It has three main antigens, O, K, and H antigens. You know these antigens. Previously, we have described them to you. They have pili. There are two important types of pili for attachment, and they play important role in the pathogenesis of the microorganism. Type I and type P. Type I binds to mannose moiety at the perineal and periurethral area. فإذا الإي كولاي attach to the perineal and periurethral area by type 1 pili. Type B or P pili binds to the kidney and the bladder and to the ureter, okay, via galactose receptor. And E. coli can produce the following cytotoxins or oxotoxins. Exotoxin of E. coli in relation to UTI. Alpha hemolysin, which is pore-forming cytotoxin, يثقب الخلايا، يعمل ثقوب pores, pore-forming cytotoxin. Cytotoxic necrotizing factor, remember this, CNF, cytotoxic necrotizing factor. It has A and B portion. B is for binding, A portion is toxic portion. So it is toxin. It can cause disruption of the G protein, which is the signaling protein. You know, الخلايا بها system اسمه G protein system, which is signaling, ينقل الإعازات. For this factor, CNF can destroy or disrupt G proteins. Shiga toxin, Shiga from Shigella. So this toxin is present both in Shigella and E. coli and other microbes also, produced by E. coli as well as Shigella. Again, it has A and B. B for binding. A is the part that blocks protein synthesis. Enterotoxins, we have spoken about them in the GI, and we said heat stable, ST, and heat labile, LT, enterotoxin, which can cause a lot of signs and symptoms related to the GI. Pathogenesis of E. coli. Any minor trauma or mechanical disruption, for example, you put a catheter, will admit the E. coli to the bladder. تدخل الإي كولاي منين؟ من البرينيال area أو البريوريثرال meatus. And these E. coli, we call them uropathogenic E. coli. You remember we have spoken about many types of E. coli previously with the GI, enterotoxogenic, enteropathogenic, etc. Today we speak about uropathogenic. You remember I've told you at that time that we are going to speak about uropathogenic E. coli when we talk about UGS. These E. coli have two types of villi. Type 1 or type I villi, which makes the microbe attached to the periurethral and perineal areas. Type B make the microorganism attached to the bladder and kidney for colonization. Now, the P. villi, usually or generally speaking, about 20% of E. coli in general, I am talking, have P. villi. However, the E. coli, which are causing pyelonephritis, more than 70% of them have P. villi. This means that those which invade to the urinary tract have more of them have P. villi, about 70% of them. Villi I on and off, يعني مرات expressed, مرات not expressed, used by the microorganism for swimming and attachment, adherence. The P. villi receptor, as I said, galactose, which is present in the renal pelvis, that is to say the kidney, in the bladder and in the ureter, and they may cause pyelonephritis in the kidney. The microorganism has a flagella. So these microorganisms are motile. Remember, E. coli is a motile microorganism, because we are going to speak about another lactose fermenter microorganism, Klebsiella, which is non-motile. So you have to differentiate between E. coli and the Klebsiella. These microorganisms produce alpha hemolysin, which can cause pores, and CNF, also, which can cause injury to the urinary tract. This is how the E. coli can cause urinary tract infection. These E. coli are present around the urethral meatus and in the perineal area. They attach via type 1 or type I receptor, which is the mannose receptor. Once they enter into the urethra and go to the bladder, if they have the P. villi and the receptor is gal, as I said, they will attach to the bladder. And those which do not express the P. villi will be washed out to the outside, because cannot attach to the bladder. Those which attach to the bladder now multiply and can ascend via the ureter to the kidneys and go there and cause pyelonephritis. So by the pupilli, they can attach to the bladder and then migrate through the ureter up to the kidneys. Treatment usually empirically حسب ما احنا معرفتنا. The microorganism E. coli in general is resistant to ampicillin. So you can use other antibiotics to start with until the culture will be available, like cotrimoxazole or fluoroquinolones, and you know these antibiotics. And then modify according to the culture and sensitivity. Klebsiella, gram negative lactose fermenter. كونها lactose fermenter microorganism, so we have to differentiate it from E. coli because these two microbes are lactose fermenter. The most important species of Klebsiella is Klebsiella pneumoniae, which is the most common species, SPP species. This microorganism is capsulated, has polysaccharide capsule, surrounded by a capsule. That is why it is non-motile. There are more than 70 serotypes according to the capsular antigen. The capsular antigen has similarity to Streptococcus pneumoniae. So there is a cross reaction between Klebsiella pneumoniae and Streptococcus pneumoniae and Haemophilus influenzae. Also, Haemophilus influenzae type B is capsulated microorganism. فإذا هل الثري microorganism are capsulated. Klebsiella pneumoniae, Streptococcus pneumoniae, Haemophilus influenzae type B, all of them are capsulated, and there is a cross reaction between the antigens. These capsular antigens interfere with the complement activation. You know, the capsule interfere with complement activation and also interfere with phagocytosis, if you remember. The colonies appear pink, lactose fermenter on McConkey's agar. However, because of the capsule, they are mucoid. مائلة إلى أن تكون الكولونيز مخاطية, mucoid and glistening, while the E. coli colonies are dry colonies. الانفيك phenomena is opposite to the E. coli, عكس ال E. coli. Negative, negative, positive, positive. حكينا بالإي coli positive, positive, negative, negative. While in Klebsiella, negative, negative, positive, positive. So you can see the difference. Klebsiella mucoid colonies, glistening, while E. coli colonies are dry colonies. Both of them are pink in color. Why pink in color? Because they appear pink because of lactose fermentation, which is present in the McConkey's agar. Treatment of Klebsiella, commonly resistant to many antibiotics. So it's better to use combinations. For example, ampicillin, sulbactam, piperacillin, tazobactam, just to protect the penicillin. Also, you can use new cephalosporins, fluoroquinolones, like what? New cephalosporin like cefepime, fluoroquinolones like levofloxacin, gatifloxacin. These are new fluoroquinolones. Levofloxacin is used commonly here in Jordan. Levofloxacin is one of the new fluoroquinolones. Cefepime is fourth generation cephalosporin. Enterobacter, gram negative. Look here, Enterobacter is rapid lactose fermenter. يعني الإي كولاي والكليبسيلا هم lactose fermenter. الانتيروبacter also lactose fermenter, but can change the color of the media to pink very rapidly. Within a few hours, up to 5 hours, they change it. Also motile microorganism. They belong to family Enterobacteriaceae. These microorganisms are less virulent than Klebsiella, less virulent than E. coli. Usually detected in mixed infection. يعني you get مثلا Enterobacter plus Staphylococcus. Mixed infection. Treatment ampicillin لأنه less virulent. First generation cephalosporin. Later generation of cephalosporins also can be used. That is to say, the new generation, second generation, third generation. Mutants يصير بيها طفرات وراثية to produce beta lactamase enzyme, so become resistant to cephalosporins. R, it means resistant, and S, sensitive. So they are resistant to ampicillin and first generation cephalosporin, although sometimes some people use these antibiotics as empirical, but you have to remember they are not as effective as the new generation of cephalosporin. So usually resistant to the classical treatment, which is ampicillin and first generation, because of mutation. Mutation will produce beta lactamases, which can destroy ampicillin and first generation cephalosporin, while the new generation are more resistant and can be effective against these microorganisms. Proteus, gram-negative, but non-lactose fermenter. Very motile microorganism. They can produce swarming phenomena. That is to say, movement on the agar growth. I will show you a picture. The growth is very bad odor, has very bad odor, called fishy odor. We have two main species. There are other species, of course, but the main two species are Proteus mirabilis and the Proteus vulgaris. What is the difference between them? Mirabilis indole negative, vulgaris indole positive. Also, these microorganisms are urease producer, so they are urease positive. And because they have urease, they lead to the stone formation in the urinary tract, especially in the kidney, because the urease break urea and produce ammonia, and this will lead to the alkalinity of the urine. Once the urine becomes alkaline, it will lead to infection, especially by Proteus, and also can lead to stone formation. Some are sensitive to penicillins regarding treatment. Others are resistant to ampicillin and cephalosporins. So it's better to use a new generation of cephalosporins or the new ampicillin groups. This is the swarming phenomena, successive waves on the surface of the agar. If you inoculate the microorganism here, it will move على شكل موجات. This is called a swarming phenomena. Urine culture. How to instruct the patient to give you or to give the lab sample for culture. Usually the voided urine may become contaminated from the urethral flora, especially in females. It may become contaminated by perineal and vaginal flora. Urine is usually sterile normally, but during voiding, المريض من يجمع الإدرار may become contaminated. أنت جاي تعمل culture منه، ولهذا السبب how to decrease the contamination. Tell the patient to clean the periurethral area before voiding. Then flush the initial part. بداية الإدرار يتركه. So the patient will collect clean voided mid-stream urine, منتصف الإدرار. بداية الإدرار يتركه. عشان إيش؟ الفلورا اللي موجودة باليوريثرا تروح will be washed out. Sometimes we can collect via the catheter. You can collect urine via the catheter. Sometimes, especially in children, suprapubic aspiration mainly is used in children. And also, when you do culture, you have to quantitate نعد عدد البكتيريا. في طريقة معينة يعني نعد عدد البكتيريا على الكلتشر, which is the gold standard for detection of UTI. In cystitis, the numbers of microorganisms less than 10 power 5 per ml, يعني أقل من 100,000 microorganism per ml. In pyelonephritis, more than 10 power 5 per ml, أكثر من 100,000. وهذه في الطريقة جيدة. This is the last slide, and it's a graph here. When you collect urine by catheter or by void, يعني يتبول المريض, usually if he is normal, uninfected, the microorganism usually between 10 power 2 to 10 power 3, يعني عدد الميكروأورجانيزم بين 100 وال1000 per ml إذا not infected. If he has got or she has got cystitis, the number is usually less than 10 power 5, أقل من 100,000. If it is pyelonephritis, the number is more than 10 power 5 microorganism per ml. طريقة عد الكولونيز إلها في طريقة حسابية إن شاء الله تشرح لكم في المختبر. By this we end this lecture. Any question?
دكتور
نعم.
سلايد رقم 6 لو سمحت.
نعم.
الدي سلاش تي ليش ترمز هاي؟
نعم.
الدي سلاش دي اللي بعد اليوتريتس.
سلايد رقم 6 هذا مو؟ شو عندك سؤال عليه؟ شو سؤالك عفوا؟ الو صوتك بس شوي.
دكتور
نعم. الو عيد السؤال من فضلك.
الدكتور كان بده يسأل إنه الدي سلاش دي لإيش ترمز؟
على السلايد هذا.
urethritis is a DD.
دي differential diagnosis.
شكرا دكتور.
differential diagnosis أنا حكيتها بالكلام. يعني how we differentiate between urethritis and cystitis. Urethritis is a differential diagnosis, يعني للتفريق. مرات تختلط الصورة علينا بين اليوريثرايتس والسيستايتس، فكلمة يعني مستخدمة بالطب إن شاء الله راح تستخدموها بكثرة من السنة القادمة. دي differential diagnosis.
يعطيك العافية دكتور.
عفوا. سؤال ثاني.
دكتور البيب لاي تبعت الايكولاي كيف يعني اون اوف؟ يعني الاورجانيزم مرات
هذه تبع البيلاي نمبر 1 او اي، يعني مرات المايكرو اورجانيزم اكسبريسد مرات نوت، يعني مرات تظهر البيلاي مرات لا تظهر. المايكرو اورجانيزم ما تحتاجها do not express the pili. If they need it, it's used for swimming and attachment to the perineal and periurethral area. On off.
شكرا دكتور.
عفوا. سؤال كمان.
ايش يعني انه البروستاتايتس not infectious؟
البروستاتايتس يعني انت تعرف اليورينري تراكت انفكشن the patient may transmit the infection via the things that I have mentioned here. You can see it. A prostatitis, usually the microbe inside the prostate and difficult to get outside the prostate. That is why even the treatment is difficult of a prostatitis. Sometimes in order to get the microorganism outside the prostate, we make what is called a prostatic massage, okay? Just to make discharge from the prostate so the microbe will be liberated outside the prostate. So
تمام
microorganism is usually hidden inside the prostate. That is why it's not infectious in general.
تمام دكتور شكرا.
عفواً. Other question? Very interesting questions. Really very interesting. It means that you are following the lecture in excellent way. Other question? Other comment? If no, I stop the lecture here and to see you, inshallah, during this week with a small group discussion and also another lecture, the second lecture. See you then. Assalamu alaikum.